Hello guys, welcome. So today in this video we have started a very important series, keeping in pace with all the new trends which have started. So this is a new VBQ series, that is your video based questions. Okay, so let's not waste further time and let's get into the videos. So this is purely the orientation wise, how they're going to frame the questions, what are the videos which they will put up in the exam, and how do they ask questions based on it. So I've come up with few important videos from orthopedics. Hello guys, welcome. So today in this video we have good evening Anuj Kumar. So let's start the first video. So here is the first video. So I want you all to first see the video and then we will come up with the question. Sure. Okay, this is the first video. So you can see there is some problem with the thumb, and this is the history of that particular video. So it is a 48 years old woman who had diagnosed with type 2 diabetes, presents with pain at the base of her right thumb. The finger in flexion gets caught in the flexion while gripping objects and suddenly snaps into extension with effort. The most likely diagnosis would be, is it a diagnosis of Dupuytren's contracture or a trigger thumb or a trigger finger, decurvent stenosynovitis, or Botchinia's deformity? So what do you think is the answer? Yes, very good. So this is just a clinically based question. So once you see the patient in the OPD, so this is how you would diagnose it. So this is the answer is the trigger thumb. So here the answer would be the trigger thumb, right? So what is that actually happening in that particular video? If you see it again, so there is a flexion which is caught, and when the patient tries to extend the thumb, it happens only with the effort, and she can hear the audible sound. So there would be a sound which they can hear, and there is an effort on extending, right? So what do you think is the pathology of the trigger thumb? Yes, the next question is exactly what he's thinking. What Anuj is thinking is one question ahead. Which anatomical structure is divided during the procedure option? So before that, what do you think is the pathology? So here the pathology is mainly the tendon. It is the tendon which is suffering because of the synovium, right? Because of the synovial sheath which gets caught near the pulley. And this is what? Which pulley has to be treated? Which pulley has to be treated, which anatomical structure is divided during the procedure options. So usually what we do, we first treat it with the conservative treatment, like we give rest to the part. Uh, we can actually try some NSAIDs, and then if the patient is having severe pain and if it is severely painful, then we have to go for a surgical procedure. And what is the release of that anatomical structure? Yes, this is the A1 pulley. So the A1 pulley is the one which we release during this trigger thumb or the trigger finger. Okay, so these are the set of questions which they can ask. They can just put the upload this video, and then they will ask you related to that particular video. So I have come up 1 or 2 3 questions. So this is the first video, so everybody who has joined late can see this video, right? So I'm asking the patient to do flexion and extension. So flexion, it is caught in the flexion. That means the patient finger is in flexion, and whenever she's trying to extend it, there is a forceful extension. And the treatment, which anatomical structure which is divided during this is, yes, it is the A1 pulley, right? So next, what this could be some one more important question. Which of the following condition is most commonly associated with the trigger finger? So as you have already diagnosed this as trigger finger, there is some pathology with the tendon. There is a tendon sheath, and the tendon keeps moving in that particular sheath, and when the sheath, because of the stenosis of the sheath, the tendon can't keep moving because of flexion and extension is by the movement of the tendons in the synovial sheath. Now the sheath gets constrained. The sheath is nothing but here it is the in the form of pulley, right? So what we are doing, we are releasing that particular sheath. Okay, flexor tenosynovitis. Okay, stenosing tenosynovitis is another name for the trigger thumb, right? And now what is this trigger thumb? Because of this because of the stenosis which is happening in the tendon sheath, the tendon is unable to move, and now we are removing the stenosis at the tendon sheath, right? So that is your tenosynovitis. Okay, and now what do you think is the most common condition which is commonly associated with the trigger finger? Do you think is it rheumatoid arthritis, ankylosing spondylitis, gout, or diabetes mellitus? So now based upon these questions, you can rule out ankylosing spondylitis because it is mainly the axial skeleton, and gout usually affects the bone. Here we are talking about the tendons. Now we are left out with rheumatoid and diabetes mellitus. So here the answer is diabetes mellitus. So it is the DM. So usually commonly patients who suffer with diabetes, we see this trigger finger or trigger thumb. Yes, the answer is diabetes mellitus, not rheumatoid arthritis. It is mainly diabetes mellitus. Okay, the most commonly associated condition with the trigger finger. Most common with the deformities, it is your rheumatoid arthritis, but here it is a tenosynovitis, inflammation. So it is most commonly your diabetes mellitus. Can you tell one more important condition which is again related to diabetes mellitus in the hand itself? Yes. So here you can see. So can you see all these four options, and can you say one more important option which is related to diabetes mellitus? Yes. Yes, Danush, diabetes is the correct answer. Okay, even the Dupuytren's contracture is also most commonly seen with diabetes mellitus and liver cirrhosis. Okay, so these are some of the common conditions which have been associated. Okay, so these are the potential questions which can be which they can ask. Yes, very good, Anuj. Yes, even carpal tunnel syndrome is also commonly seen in diabetes, but usually what happens is carpal tunnel syndrome, sometimes in women it is most commonly seen in pregnancy or post-pregnancy and hypothyroidism. Yes, diabetes also understood, but it is also related to other condition. Okay. Yes, so that is about the trigger finger. So these are the questions. So usually they can't elaborate and tell you what is a trigger finger, right? So they will tell you that so all this sound is heard, there is effort in extension and all. Otherwise, they will put a simple video like this and they will ask you what are the diagnosis. Fine. So that is about the first video. Now coming to the second video. So are you able to see the second video here? So here is the man. So just see the video first, then I will give you the question. So this is the video. So you can see a man here. So this is the history of that particular video. So here a 52-year-old man presents with pain while abducting the right shoulder as shown in the video, which demonstrates pain during initial abduction. Which structure is most commonly involved? Which structure do you think is most commonly involved in this particular person? So once again, I will play the video. So you see this this person who is 52-year-old man has come with the pain in the shoulder, the right shoulder, and as the person walks in, we will ask him for the movements, right? How are the movements? So what he told was there is a pain in the abduction. So there is a pain in the abduction, right? And here also you have to be careful. So there is no diabetes mellitus which is say. Can you tell me one more important condition where we'll see that association of the diabetes mellitus in the shoulder? One condition of shoulder which is associated with diabetes mellitus? Yes. Yes, all your answers are perfectly right, but can you answer my question? One common condition in the shoulder again associated with the diabetes. What do you think it is? Yes, quickly. Yes, very good. Whenever we talk about the initial abduction, so here they have told you that the pain is there during initial abduction. So whenever they talk about abduction initially, no doubt it is the supraspinatus tendon which has been torn. So the problem here is supraspinatus tendon. Okay, fine. And then yes, very good. The frozen shoulder. Anuj and Danush, both of you are right. So one important condition again associated with diabetes mellitus is frozen shoulder. So proper history is always useful. So once you see the video, so you will have some diagnosis in your head. So that diagnosis should be related to the history. So that diagnosis should be related in the history, right? So here a 52-year-old man has come up with the pain in the shoulder, and we have seen that there is a problem in the shoulder abduction. So initial abduction is with your supraspinatus tendon. So initial abduction is with your supraspinatus tendon. So what we are anticipating is, the anticipation is mainly the supraspinatus tear. So one more important condition associated with diabetes mellitus in your shoulder is your frozen shoulder, right? So let us see one more important question which can be asked, right? So one more important question is, the following video demonstrate pain during shoulder abduction. Which of the following sign is associated with this pathology? So already they have told you that the video has been demonstrated in the shoulder abduction is the problem. And which of the following sign? Is it the sulcus sign, the drop arm sign, the apprehension sign, or the painful arc sign? So which of the following sign is been associated with the supraspinatus? Yes, what would be the answer? Yes, Anuj. Painful arc is again for first 15 to 20 degrees you will not have any pain. So the pain is almost from 60 to 120 degrees, right? 60 to 120 degrees. So here I have told you that there is a pain in initial abduction. So can you think of this test? So which test is associated with the supraspinatus? Yes. So that test is called your MT can test, right? So what is the MT can test? So test which is associated with your supraspinatus tendon, right? And painful arc is not initial. Painful arc is somewhere between 50 to 60 degrees. He will not have any pain, and from 60 to 120 degrees he will have pain, right? And again overhead abduction he will not have any pain. Okay, so that is painful arc. But here in the video you can see the patient initially is also having pain. So here the answer would be the drop arm sign. So what is a drop arm sign? So drop arm sign is again related to the supraspinatus tendon. So how it is related to the supraspinatus tendon? So now we are going to ask the patient to abduct and hold the arm for at least 10 to 15 seconds. So if the patient is unable to hold the arm with 10 to 15 seconds, what will happen? There is a tear in the supraspinatus and he will immediately drop the arm. So this is called the drop arm sign. So this is called the drop arm sign. So painful arc is for initial at least up to 60 to 70 degrees is able to do, and from that to 110 to 120 will have pain, and over abduction is again painless. So here initially only patient is unable to lift the arm, right? So let us go back and see the video once again. And I have hold his arm. So now let us see the video again. So if you see initially only is unable to lift it, right? So the painful arc, what he can do, he can at least lift it up to 60 to 70 and then overhead 120. After 120 it is painless, right? So here if you see, I've asked him to hold the arm. Okay. And then he's unable to hold it and he's dropping it down. Okay. So this is called as the drop arm test or the drop arm sign, which is seen in the supraspinatus tear. So this is the drop arm sign or the drop arm test, which we usually seen in the supraspinatus tear. Now, can you tell me where you see the sulcus sign and the apprehension sign? So sulcus sign is mainly again in the instability, glenohumeral instability. So that is again habitual or recurrent dislocation. So whenever there is a problem in the shoulder, so inferior, if the shoulder is dislocated downward, so this is called the glenohumeral instability, and there you can see the sulcus sign. Apprehension sign is also for the recurrent shoulder dislocation, right? So this is for the recurrent shoulder dislocation. Fine. So this is about the sulcus sign, drop arm sign, apprehension sign, and painful arc sign. So painful arc sign, initially there is no pain. 60 to 120 there is pain. Again on 120 it is painless. Fine. Yes. Moving on to the next video. So let us see what is happening in this video. So this is the video where you can see the squeezing of the calf muscles is causing what? The plantar flexion of the foot, right? So now the question related to this. So the video demonstrate the Thompson test, right? So you have all identified that this is the Thompson test where we do it for the Achilles tendon, right? So there will be squeezing of the calf muscles and you will see there is a plantar flexion. Now the calf muscles resulting in no plantar flexion of the foot on the opposite leg. So the test is based on assessing the integrity of which tendon. Is it the flexor hallucis? Sorry, that's a typing mistake. It is a flexor hallucis, not hallucination. Flexor hallucis longus tendon, Achilles, plantaris, peroneus brevis. Yes, most of them will do this right. So if asked about the Achilles tendon and the Thompson test, I think most of them will do it right because we have learned it that the Achilles tendon and the Thompson test is the test which is used to identify the Achilles tendon tear or rupture. Okay, so now answer this particular question. Now, a 38-year-old man presents with acute pain in the posterior aspect of the ankle after hearing a pop sound while playing badminton. Okay, a video demonstrates a positive Thompson test. So we have shown you a video also. It is showing the Thompsons, not Thompson, Thompsons. Okay, and what is the next best investigation to confirm the diagnosis and plan treatment? So this was asked in the NEET or INI-CET last year. So they have shown you the MRI of the Achilles tendon and this is the question. So we have learned about the Achilles tendon tear and how to identify it by the Thompson's test. So now let us understand what is the next best investigation. So always you have to see what is the best or the next best investigation. So these two are very important. Either they are asking you the next investigation or they are asking you the investigation of choice. Okay, so while dealing with tendo-Achilles, two things you have to remember. So first, you will always identify with the clinical evaluation perfectly. So history and clinical evaluation is always important, but here they're trying to confirm the diagnosis. So how do you confirm the diagnosis? So confirm the diagnosis is always by imaging. And they have asked you the next best. So next best is always ultrasonography. So in the ultrasonography, you will identify that there is a tear or rupture or what is the distance between the two fragments, right? And when you're planning for surgery, then you can opt for MRI. If it is a complex case or if you want to see the rupture is from the bone and all, okay, right? So MRI is not required in all the cases. So MRI is required only for few cases, right? But what is the next best investigation? Yes, not the gold standard. Yeah, gold standard is always MRI. Yes, so next best investigation is always your ultrasonography, right? So next best investigation is always your ultrasonography. Fine. So here that the surgery, complex cases, you can see it is the MRI. So complex cases is the MRI. Okay. Yes, very good. Ultrasound. MRI क्यों नहीं? Because you can diagnose it on the ultrasound, right? Why you want to go for such huge investigation? So ultrasound it is, you can directly do it in the OPD, right? Okay. So first the patient, you will take the history, then you do the Thompson's test, then you confirm that there is a tear in the tendo-Achilles as we have seen in the video, then you have to go for an ultrasound. So in the ultrasound they'll tell you that whether it is the rupture had happened or not, or if there is a rupture, what is the amount, what is the distance between the two fragments. If the distance of more than 6 mm, then you can think about surgery, right? If it is less than 6 mm, you can still try the conservative treatment, right? So never only clinical evaluation, because you need to confirm it by imaging. So this is not the answer, not a radiograph, because nothing you will see on the radiograph. The answer is ultrasonography of the tendo-Achilles, right? And now I want you all to answer this. So this was exactly asked in the exam. A 28-year-old Clinically, we have completed, right? Clinically, the video demonstrate a positive Thompson test. So clinically, it is evaluated. The option says there is no imaging which can be done. Only clinical evaluation is the confirm the diagnosis, or there is imaging. So the answer is ultrasonography, not only clinical evaluation. Okay. In this particular question, clinical evaluation is done through the video, that is Thompson test. So after that, next is ultrasonography. I think you got that, Anuj. Okay, now I want you all to answer this question. A 28-year-old professional basketball player has a complete Achilles tendon rupture as demonstrated. So now you have seen the video. There is no plantar flexion. That means there is a complete tear. He has confirmed the complete rupture and the ultrasound as well. So here the next ultrasound is also done. Which of the following is preferred treatment? So this is how the questions can be framed. So the first question is very easy. Just they'll ask you what is the tendon, okay, or what is the test. Then they will escalate to what could be the next investigation, that is your ultrasound. And once even the ultrasound is done, what is the preferred treatment? Will you treat him with NSAIDs? Will you do surgical repair? Will you give steroid injection? Will you put a long leg cast for 12 weeks? Very good. All of you are right. So the answer is always surgical repair. Yes, complete rupture and in the athlete. So whenever there is an athlete, professional basketball players, what you do, you repair, because NSAIDs and unrestricted will not help them. No steroid injections for Achilles tendon. This will result further rupture. So remember, no steroid injections into the tendons. Never. Steroid injections only into the joints, but never to the tendons. No any tendon, no steroid injection. Long leg cast, which is not very apt for this patient. So here the answer is surgical repair. Yes, you have to suture. You will use the sutures and you repair the tear. You repair the rupture, and then you do early function rehab, because he is a young individual with a complete tear which has been diagnosed on your ultrasound. So partial tear, you can still go for your cast. Okay, if the patient is able to take rest for 6 to 12 weeks, you can put him a cast, or you can give him boot. So there are boots which are available now. It is like the cast. He can put that boot and he can walk for 3 weeks. For partial rupture, you can still go for the conservative treatment. Okay, is that clear? Yes. Any other doubts? Okay, if no doubts, moving on to the next question. Okay, this is all your favorite. Yes, I know you will, all the bulbs have lightened. So what is this? Yes, exactly. That is the answer. I know you all know this answer. It's very, very easy. No need to, beat around the bush. So the video demonstrate a patient who is attempting to hold a card between the index and the middle finger while the examiner pulls it away. The patient is unable to maintain the grip. Which of the following muscle group is primarily being assessed? Very good. Excellent. So this is nothing but your card test. And I want everybody to be very, very sure that this is the ulnar nerve palsy. Very good. So card test, ulnar nerve palsy. But I am waiting for the answer. What is the answer? Which following muscles group is primarily being assessed here? Answer is? Very good. Yes, the Palmar interossei. So Palmar interossei, you have to remember the pad and the dab. So pad and the dab. So Palmar is for adduction. Dorsal interossei is for abduction. So Palmar is for adduction. So here we are trying to adduct the fingers. So here the muscle group which is being tested is your Palmar interossei. So then muscle group which is being tested is your Palmar interossei. Okay. Yes. Now, can you tell me what is the nerve supply of this Palmar interossei? Is it, yeah, ulnar nerve, but it is the deep branch of the ulnar nerve. This you have to remember, because they keep asking the branch. So deep branch of ulnar nerve. So the muscle supply of the palmar interossei is the deep branch of the ulnar nerve. Yes, the IGAVA is for your dorsal interossei. CAR test is for palmar interossei. And then one more important test, Frohman sign or the book test is for your, yes, book test or the Frohman sign is for your, yes, this Frohman sign is for your adductor pollicis, right? So that you have to remember. One more important muscle, that is your adductor pollicis. It's a thenar muscle which is supplied by the ulnar nerve for your book test. Okay, so that is about your CAR test. So I hope most of the questions you will answer from the nerve injuries. So they can ask you about the muscle group, they can ask you about the nerve supply, they can ask you about the what test is being done, right? And finally, what is the treatment for ulnar nerve palsy? Treatment for the ulnar nerve palsy, knuckle bender splint. This you have to remember. So the treatment would be your knuckle bender splint, right? So the knuckle bender splint is being used for your ulnar nerve palsy. For what, Ankit, you have typed median? Adductor pollicis is supplied by which nerve? It is supplied by the ulnar nerve. Okay. Pen test is median nerve. Remember, pen is for median, book is for ulnar. Fine? Yes. Okay. Now we'll see with, yes, knuckle bender splint. Yes, fine. Yes, ulnar. Perfect. Now, next video. Next video. So here, what is the woman doing? Just observe the video. I will give you the question. So now this is your question. A 60-year-old woman presents with pain in the shoulder after a fall. The video demonstrates which of the following tests and what is the next best investigation to confirm the diagnosis. Yes, is it a lift-off test and the confirmation is by ultrasound shoulder? Is it a belly press test and your confirmation is by ultrasound again? Is it a belly press test and confirmation is by the MRI? Or bear hug test and the confirmation is by MRI? Yes, Dinesh, you have identified correctly. There is a problem in the internal rotation. You're right. Dinesh, why did you delete it? You're right. There is a problem in the internal rotation. The patient is unable to internal rotate her shoulder. Right? So what is this test called? Okay, belly press test, half correct. Lavender girl, half is right. What is the other half? Think, what is the next best investigation in case of your rotator cuff injuries? So this is the rotator cuff injury. So what are the rotator cuff muscles? We have already dealt one. So one is the supraspinatus. Second one is the infraspinatus. Third one, teres minor. Last and important one, your subscapularis, right? So supraspinatus you have dealt, it is abduction. These two are for your external rotation and subscapularis is for your internal rotation, right? Yes, very good. Sits. All these are your rotator cuff muscles, and the infra and the teres minor is for your external rotation. So you're moving like this. And your subscapularis, if you remember, it is present on the anterior aspect of the shoulder, right? So it is for your internal rotation. So this is called the bear hug. So putting the shoulder on the opposite shoulder, making your this palm putting on the opposite is your bear hug test. So this is called the bear hug test, right? And what is this, which I have shown in the video, where the woman is putting the two palms on the belly button and trying to press it inside. So this is called the belly press test. So this is called your belly press test. So what I have shown here is the belly press test, and this test is for your subscapularis. And here don't get confused with the next best investigation, because each part of the body is diagnosed separately. Because I have told that Achilles tendon is ultrasound, that doesn't mean everything will be ultrasonography. Okay, here the rotator cuff is difficult to identify on the ultrasound, so here the answer would directly, we will put the patient to MRI, right? Tendon-Achilles is a very big structure which can be easily seen on ultrasound. Okay, so that is why we go for ultrasonography. So here the investigation of choice, the next best or the investigation of choice is your MRI. So MRI rotator cuff or MRI shoulder you see, and there you will see or identify the tears or ruptures or the degeneration of the subscapularis. So here we are discussing about your subscapularis muscle, right? Which is important for your internal rotation of the shoulder. And what are the three important tests we do for subscapularis? Yes. So one is, I have told you, the belly press, right? The second one I have told you, the bear hug. And third one I want to tell you. Third one, the third important test for the subscapularis. Yes, everybody? Third important test, I'll wait. Yes, forgotten tendon subscapularis. Yes, what is the test I'm waiting for? Is it the belly press, bear hug test, and one more important test is there for subscapularis? Yes, lift off test. So Gerber's lift off test is one more important. So how do you lift off? So here, if you remember, I have asked the patient in the first video of supraspinatus. So you see the patient is putting his hand back and is trying to lift off. So you will put the hand on the back and you try to lift off this test. So this is called the internal rotation, lift off. Right, so all these three are important for your diagnosis of your subscapularis, and then you will put the patient to MRI for confirmation or the next best investigation or the investigation of choice for the plan of the treatment, all MRI shoulder. Okay, yes, this is actually an interesting case. So this patient, just see the video first. So now this is an interesting case again. See what is actually happening. Look at the arm. So what is happening to the arm? What is the arm doing to the shoulder? So you can see we are asking the patient to lift her arm, and then there is a swelling which is appear in the arm, and then when she puts down, she is able to do it normally. Yes, perfectly, Dinesh. So this is the question. This is an 8-year-old child who is able to repeatedly dislocate and spontaneously reduce the shoulder by hyperabducting the arm as demonstrated in the video. There is no history of any significant trauma. What is most likely the diagnosis? Is it the anterior shoulder, habitual inferior, or posterior or multidirectional instability? Yes, yes, that's correct, but it is mainly for the acute trauma we use the term. Luxio erecta. So here the answer, if you see the video, the straightforward video, it says that it is a habitual inferior shoulder dislocation, right? So the patient is able to inferiorly dislocate the shoulder, and here the mechanism of the injury is hyperabduction. So whenever you see hyperabduction, it is if it was because of trauma and the patient comes in hyperabducting position, it is very rare and patient will unable to reduce it down. But here she is able to lift it and then put it down. Okay, so this is a habitual inferior shoulder dislocation because of ligament laxity. So this is the habitual inferior shoulder dislocation. This is the answer. Now, the interesting fact is how the patient has presented to the OPD. Here comes his father who brings this 8-year-old child telling us there is a swelling over the axilla that appears on hyperabduction and disappears on adduction. So the child can voluntarily reproduce this phenomena without significant pain. This is what the initial history was. And when we have done clinical examination, this is what we have seen. Okay, so it is entirely different from the history to the clinical examination. So what they have described is they have told us that there is a swelling in the arm and this swelling appears on hyperabducting, and when the shoulder is put down you can see the swelling disappears. So this is what the history was, but on the examination you see what is that swelling which is coming inside the axilla and going up. It is nothing but your humeral head, right? So that is the shoulder dislocation, which is again a habitual shoulder dislocation. So this is a habitual shoulder dislocation which is happening. Okay, so this history can be so misleading, right? So this is the beauty of putting the videos which you can assess the patient completely. So this is not any axillary lymphadenopathy or osteochondroma or a deltoid muscle herniation. This is nothing but a purely shoulder dislocation which is happening on the inferior aspect. Okay, is that clear? So hope this video based questions have helped you. We'll come up with more interesting videos in our next session. Any doubts you can please put on the comment box, or you can ping directly to Dr. Alekhya Ortho on the Instagram, right? Or you already know that PW Meded has its own Instagram channel, so you can Instagram handle, you can text there as well. Any other doubts you have? So these are the few videos we have come up collectively, and the questions, if you see, it is not about the new question or something new out of the box. It is the old questions only in a new format. So don't ever worry about what is being come up with some RTA trauma VBQs. Surely we'll come up with all the videos possible. But what I want to tell you is don't concentrate on what is asked, like this VBQ or new things which are being adding up. The whole base is your concepts. So please be clear in your concepts and understand each thing separately and deeply. Okay, so this is how they've been asked in the exam also. Hope this will help you. I've surely come up with other interesting videos. Trauma is bit difficult videos because the patient will be in pain, right? So only thing we can do is once the pain gets reduced for IT, IC we can do, but fractures, it is usually difficult in that, when we keep dealing with the patients, we just don't remember to take the videos, right? So that is it. Thank you so much. See you all again in the next session.